Welcome back. My name is Trix Ingado. On this part of Morning Prime, we're going to talk about gender issues and specifically reproductive health. And this is one of the key areas that would actually affect a country's economy, future generations. And in order for this to be something that is taken care of for all communities in this country, there needs to be specialized care. But unfortunately, there isn't enough of doctors and specialists to go around, particularly in marginalized areas. So we're going to talk about that and much more with our special panel that we have set up for you. Today we have the Executive Director for Reproductive Health Kenya, Nelly Munyasia, as well as the President for the Gynecology Association of Kenya, joining us this day to help us discuss this very, very critical subject. And the President of the Gynecology Association of Kenya is Dr. Kireki Omanwa. Thank you so much for joining us this morning. Now, it's very interesting data that has come out that this country only has 500 gynecologists. Explain how the severity of the problem to us, Dr. Kireki.
Actually 506 to be exact.
506.
506
okay.
Consultant gynecologists. First of all, thank you for inviting us to the studio to talk about such a very important issue. I'll start by sort of taking a step back. 2 weeks ago, in one of the WhatsApp groups that we are, one of our colleagues sent a picture, which was a picture of the standard. I think it was in 1970, when the medical school was actually started. And it said, now we can train, medicine can actually be taught in Nairobi. It was a momentous step, as it were.
Yes.
So 50 plus years down the road, we have actually done quite well. We are producing our own doctors, we are producing our own subspecialists, and even we have started producing our own subspecialists. I'll go a little bit further. Some of our African countries who are our neighbors actually do not produce specialists. Last week is when I saw an article in one of the international journals where Botswana actually has just started its specialist training in obstetrics and gynecology. So we have made advances, huge advances, but we are still not yet there. At the Department of Obstetrics and Gynecology, University of Nairobi, we train specialists for other countries. We have students now, we are teaching from Sierra Leone, from Liberia, you know, and so on, from the Gambia and so on. So we are doing a tremendous job as a country. The government has done quite a lot, but then it also leaves a lot to be desired.
Absolutely.
In a year, University of Nairobi, last year, in July last year, we graduated 34 specialists, which is a good number. The number has been increasing year by year, which is very, very, very good. The only problem is that out of all the 506 consultant gynecologists that we have in this country, most of them are actually situated in the big countries, in the big cities, in Nairobi, Mombasa, Kisumu, Eldoret, Nakuru, and so on. We have large swaths of this country which have absolutely no consultant, or even if they have one or two consultants, that is absolutely nothing. It's a drop in the ocean.
Yeah. And the WHO standard is 1 doctor for 1,000.
That is a different story
that is just doctors. Yes, it's not about specialists, just doctors.
We are just talking about doctors.
Yeah, right now we are at 1 to 10,000. So when it comes to these specialists, the numbers are even worse.
They're even worse. They're even worse. But then somebody could say, I mean, while gynecologists, you are not doing too badly. For example, neurologists, neurosurgeons, there are about 20 in this country. Not to talk about pediatric neurosurgeons, we may not have, or we may have one. Pediatric cardiosurgeons, for example, we may have one, we may have two, etc., etc. But coming back to what we are talking about today, we're talking about the spread. How do we spread these consultants, you know, in all these marginalized areas? You find a place like Turkana. I talked here last week on Friday with a colleague of mine and told me, look, even the one consultant who was remaining there has actually been poached to go and work in an NGO. So But as we are talking today, most probably Turkana does not have a consultant, gynecologist, an obstetrician and gynecologist working in the government sector.
Right. And I'd like you to hold that thought, because I would like to bring in Ms. Nelly Munyasia, who is of the Executive Director of Reproductive Health Kenya. And later on, I'd like you to paint us a picture what that actually means on the ground.
Absolutely.
When we only have even none of these specialists in certain areas. Ms. Munyasia, reproductive health is all about before, during, and after, and in between children. Explain to us why this is very, very important to have specialized care.
Thank you so much. And I mean, interesting that we are meeting here. Yeah. So thank you so much for having Reproductive Health Network Kenya as part of this conversation with our great allies. We work very closely with COGS, especially on issues reproductive health, and appreciating that they are, our seniors, and they try to provide strategic direction when it comes to issues, policies, laws, etc. So like you have asked, I mean, reproductive health is very, very key for any woman. And the pre-care where, let's say, for example, it's a pregnant woman, it's important, actually it is a policy that they have to visit the antenatal care 4 times.
Yes.
And we are saying that they can be seen by a gynecologist, a midwife, and like we've talked about the numbers for gynecologists are very low. But we have midwives all over spread, both private and public practice. And we have, set up antenatal care facilities. But one of the problems in Kenya is we have not strengthened our health systems. Nevertheless, our midwives and our gynecologists are doing an amazing job in making sure that the mothers have visit the facilities 4 times during their time of pregnancy. Then immediately after delivery, there's the immediate care and the follow-up care, where we are now taking care of both the mother and the child. And as we take care of the child, we are also making sure that the mother is, progressing well, because one thing that came up, but one thing that took long for us to understand is that postnatally mothers need a lot of care from the healthcare providers because of the depression, the postnatal depression, new mothers who do not even know how to take care of babies. And then there's the baby, and then there's you yourself, the whole psychological change, the physiological change, all the changes that come with giving birth. So it's really important that we have a mother being taken care of before delivery, during delivery, where we are saying that we need close care with a trained healthcare provider, and then postnatally we need also close monitoring until that time where she can be put on an antenatal, a postnatal family planning method. But that doesn't stop at that, because there are also a lot of complications that come, a lot of issues that need close monitoring even when on postnatal.
That midwives cannot actually handle, right?
So of course,
because I'm imagining,
the midwives.
Let's say in Wajir it says there are no gynecologists, right?
Gynecologists, yes.
So imagine if there's a high blood pressure situation, preeclampsia, you know those conditions. A midwife cannot actually tend to a mother.
But situations have pushed midwives to learning and just getting capacitated. And actually, when we're talking now about taking of a healthcare provider, of course, with specialized care from the gynecologist, currently we have the government training the clinical officers on reproductive health, and this is because of the gap that the president for COGS has just mentioned. And this is in the spirit of task shifting, because too many patients, very few specialized healthcare providers. So the government has allowed for task shifting in scenarios where the mid-level providers can come on board and support. However, again, when there are complications, as you're saying, then that means that we have to refer a patient for 200 kilometers, which is sad.
And we know the state of infrastructure in some of these parts of the country. I'd like to ask you, Dr. Kireki, explain to us what it means for women who do not have this kind of service, literally.
Now, as she has just talked about here, it's very important. Number one, we are talking about life. So when you're talking about life, we start right at the beginning. Preconception, conception, delivery, and afterwards. So In some countries, what they have done, there are patients whom we call low-risk patients, meaning that they're young patients, for example, in their 20s, 25, they don't have any history of any disease. In their family, everything is straightforward. Actually, these, for example, in the UK, these are managed by midwives right from the beginning until the end. However, there are patients who are going to be complicated. Patients who have a history of, high blood pressure, hypertension, have fibroids, for example, have lost babies, and etc.
Yes.
These patients need specialist care, sometimes even subspecialist care.
Yes.
Sometimes you actually need multidisciplinary teams for us to take care of these patients. Because as you said right at the beginning, reproduction, and this is actually at the core of the economy of this country. If the country, if people stopped reproducing, actually what would stop is that we do not have economies. We would have to import people, immigrants, to come and work, which is happening in Europe, and everybody knows that. So it is of importance, utter importance, that we have these specialists on the ground to take care of these women who are or can complicate, and they do complicate every day.
Right.
For example, she's talked about task shifting, which may be a good idea, but is it the ultimate decision? I don't think so. The scope of work that she mentioned, which is fantastic, their lanes, people should keep to their lanes. They know that midwives, this is what we were trained to do from point A to point B. When it gets to point C, these ones we leave for the specialists. And once we have identified this and we know this, then it is safe for everybody. Nobody is going to take somebody to court that you crossed your lane. But now, as she exactly said, sometimes these people who are not very well equipped are actually thrown into the deep end. You have a lady who is bleeding or who has high blood pressure, and the consultant is maybe 200 kilometers away, and she needs to deliver. What do you, or she has started delivering. So maybe a phone call, maybe this, maybe telemedicine can actually become, can be one of the options that we can look at.
Explore.
Because you talked about infrastructure. Last week I talked to a friend of mine and told me, you know what, I'm disgusted because there are patients who are being sent 130 kilometers away for a scan when they are bleeding in pregnancy. So, and the roads are actually almost not there. So how does this lady move from point A to point B, 130 kilometers for a scan? And meanwhile, we actually have these scans on site, but we don't have personnel who are actually trained to do them. So we have a huge task. As professional societies, we are more than happy to step in and say, look, this is what needs to be done. And then we should work in tandem with the government. We should work in tandem with the county governments. We should work in tandem with other professional societies, with the midwives and so on, so that we can be able to actually come in and say, this is what we need to do, this is what we can do, and these are the time frames that we can do that.
And Nelly, this is not just happening in marginalized areas, even in urban settlements. Speak to us about the need for more targeted reproductive health care and what we can do to actually meet that need.
And I just want to pick from where Dr. has left, where he said telemedicine, telehealth, we have to adapt. And we are not adapting because we have options. We do not have options, And we have to save lives. And we have the senior gynecologists that are saying we are here to even have a teleconference with the midwives, have a session where we can take the midwives and the nurses, and the clinical officers through sessions where we are able to give them, to capacity build them, so that they have the information, they have the know-how on how to take care of emergencies. Because emergencies don't come knocking, they just happen. So as we think about what else do we need to do around reproductive health, especially in urban areas, for me, and COVID has taught us that we need to quickly adapt and change. For me, is advancing self-care. And when we talk about reproductive health care, sexual and reproductive health, and we talk about self-care, we are talking about telecounseling, we are talking about teleconferencing, we are talking about provision, self-testing of HIV testing and counseling, we are talking about contraceptives where you can, we have the self-injection, we are calling them the DMPSC. We have the self-managed abortions, for example, for cases that have complicated, and you know, a client can call and speak to a doctor, and the doctor will be able to assess and, you know, take history of this client on phone and do the prescription, refer them to a laboratory closer by, refer them to a pharmacy closer by, they take the pill, and the healthcare provider is able to monitor. Beyond that, I think we need to, it's high time we need to implement policies and doc, you know, what we are doing behind the scenes. We have amazing policies. Sadly, they're not implemented.
That seems to be the Kenyan narrative in every sector.
It's very sad that some of the policies which we have developed in this country have been adopted by other countries' neighbors. And they're doing fantastic. And then we say, so and so, look at what X is doing. And those policies were actually Kenyan. So we create policies, we put them on a shelf, somebody else comes and takes those policies and actually implements them, and we are shocked that they are working.
And we take them as, you know, good practices.
And then we also say, why can't we go and do whatever? Benchmarking there. Meanwhile, there are our policies. You know, we are not, I think we should be a bit more serious.
Dr. Kireki, as we talk about telemedicine, these are things that I would imagine happen in war zones. You know, you don't, you know, think of Kenya when you think about a doctor conferencing from somewhere else to help in an emergency. You imagine that we are more advanced. Before we get to that point, what can we do to ensure that we increase the number of doctors? I do understand training takes very long.
Yes.
What can we do to ensure that there are more of gynecologists in our society?
As the adage says, anything good takes time.
Yeah.
And it takes time to train a doctor. It takes time to train this consultant. It takes time to train this subspecialist. I think we need to take a step back and really take a serious account of what we have done and where we are. What we are doing, for example, as I mentioned in the, at the beginning, in the Department of Obstetrics and Gynecology, University of Nairobi, we are training about 30 to 35 specialists every year now, which is a good increase. But is that enough? Not so much. In Eldoret, Moi University also trains some. Aga Khan University also trains some. So we are making progress. Unlike in the past where we had only University of Nairobi. What is happening now, we are actually decentralizing training. We are going into a collegiate system of training, whereby, because this has been actually Achilles' heel, as it were, when it comes to training, whereby the counties are supposed to release their workers to come to University of Nairobi or to Moi University or whichever training center, and they're away for about 4 or 5 years before they go back as specialists. Now, the counties think that this is a waste of time and a waste of money because these employees are not there. A very myopic way of looking at things, because these trainees are going to go back as very well trained personnel. And the best thing any organization can have is actually human resource, and this is huge human resource. So we should be more serious with this. That is number one. Number two, as I said, we are starting, some of the specialties have actually started the collegiate training. For example, the surgeons have done it quite well. The anesthesiologists are also doing it, and so on and so forth. We, the gynecologists, we are actually on the bandwagon. We have our, what we call EXACOG, which we are implementing. There are 2-3 hospitals, pilots, which are supposed to start training soon, and there are others which are lining up to start, which is a very good thing. Why is it a good thing? Because the people who are going to train, they are training in the local hospitals. So they're actually providing that service as they are training. They are being mentored at the same time. So the county actually doesn't lose the man hours, as it were. They are working and they are learning and they're providing that service. So that is number two. Number three, one of the things that actually came out right in the beginning when the training actually started, the government actually used to pay the trainees. But then all of a sudden that stopped. There is no way we are going to make progress if government does not actually invest in this. There is no way. I had the chance of actually, the chance and the blessing of training outside this country. I trained in Poland, and I got a full Polish government scholarship, and they actually used to pay me every month a stipend. Not much, but it was enough to sustain me and my family. So we can go back to that model, and I'm sure we can have finances, and these finances are there, because if we are going to train these people and retain them, we are going to make huge progress in our indicators. Maternal mortality rates. 2018, our maternal mortality rate was 488 women deaths.
Yes.
488 deaths in 100,000. Then in 2020, it dropped to about 362, and then COVID struck. Now we most probably have crept up again, maybe even more than that, 488. So we need to actually really take a step back and integrate all these things that we have talked about, and really take stock. I mean, why should we employ foreigners to come and work for us?
Good question. And that question is going to take us to our break. As we ponder that, we're going to come back with this discussion. Dr. Kireki and Ms. Munyasi are going to dig deeper into some of the problems that are affecting the access to reproductive health, and we'll go and go into the solution bit of the conversation and try and figure out where we are headed. Even this being an election year, how can you vote for leaders who actually care about your reproductive health? Let's take a break. We'll be right back.